Ladies and gentlemen, thank you for standing by. Welcome to webinar number 2, Social Norms, Change, and Health Equity. During the presentation, all participants will be in a listen-only mode. If at any time during the conference you need to reach an operator, please press *0. As a reminder, this conference is being recorded Tuesday, September 23rd, 2014. I would now like to turn the conference over to Jim Ketty, Vice President and Chief Learning Officer at the California Endowment. Please go ahead.
Yeah, good afternoon, everyone, and thanks again for joining us on this webinar series. This is the second webinar in a 3-part series. We conducted the first webinar a few weeks ago, and that was an introduction to social norms, communications, and movement building. That included our vice presidents here, Tony Eitzen and Daniel Zingali, who shared some of the thinking here at the endowment, why we care about social norms change. And we also saw some examples of successful norms change efforts in the past through a presentation by Hadaway Communications. And we're very pleased to be joined today by 2 leading thinkers in this area of social norms change and health equity, Lori Dorfman and Katherine Schaff from the Berkeley Media Studies Group. But before we start to get into this, what I think will be very interesting content, let me just go to housekeeping. So we are recording the webinar, and you'll receive a follow-up email with a link to where you can hear the webinar. If you have other members of your staff or partners or other members of your team that would like to listen in, they can do that in the future. We're going to ask you to please hold your questions for the speakers until we get to the Q&A part of the webinar. Although, as you see, there is a chat function here, and if you would like to propose questions or comment as we move through the presentation, you can do that through the chat function. And as you saw in the chat box already, the way to hear the audio on this is to dial in directly from your phone, and that number is 1-800-738-1032. Let's go ahead and go to the next one. Yeah. So I've already been introduced. I'm Jim Ketty. I work here at the endowment as the Chief Learning Officer. I'd also like to introduce to everyone a new member of our team, Jennifer Venor, who is our Program Manager for Learning and Outreach. And Jen is now our lead person here at the Center for Healthy Communities. That's responsible for hosting public programs in the Los Angeles area as well as in other parts of the state, as well as supporting our work and training through the Health Exchange Academy. And just so folks kind of hear about the rest of the department here, our department also includes Sunena Sundhi, who is the person behind the scenes making this all work so seamlessly, and Joey Bravo. But without further ado, let me turn this over to Lori and Kathy, and thank everyone again for joining us.
Great, Jim. Thank you so much. It's really nice to be here. And it's always a little funny doing a webinar. I feel like we're talking in a dark room, but I know you're all out there because I see your names. So I tried to advance the slide, but it didn't quite work. So I wonder if you could do that for me, and then we can have the title. Thanks so much. And I'll see if I can make that work, but if not, I'll just let you know. So Kathy and I are very excited to be talking about this. It's kind of you, Jim, to introduce us as thought leaders. We feel like we are learners and discoverers because the issue of health equity and how to communicate about it is tricky. And so we don't pretend to have the answers, but we are going to share with you our own explorations, how we've done this how we've been thinking about this, and we're going to apply it. We're going to take some theory that I'm going to talk about or some ideas that have been gelling over time across different disciplines, and then Kathy's going to talk about how that has been applied at the Alameda County Health Department, and then we're going to be really eager for your questions. And in the next slide, Kathy will tell you whose shoulders we're standing on here. Whoops, sorry. There you go. Back one, yeah.
So I'm also very excited to be here and looking at the participant list on the webinar today. I know some of the organizations you're coming from and a little bit about the great work you're doing, so I hope that we learn a little bit more about that in the Q&A and thinking through how you all are communicating about health equity. And we just wanted to acknowledge that, like Lori said, this draws on information that's been gelling over many years that comes out of the hard work and expertise and ideas of a lot of people, including community residents within Alameda County, Alameda County Public Health Department and Berkeley Media staff, and all of the great partners that we work with.
For those of you who haven't heard about us, Berkeley Media Studies Group is part of the Public Health Institute, and we have a very strong interest in media, particularly the news media. And the reason we do is because we know from the public health literature that the best way to change a population's health, to make a whole population healthier, is to improve the environment in which they live. And if that's our goal, is that we really want to change system structures and improve environments, we have to pay attention to the people who can make that happen. In our day and age, this is often decision makers, sometimes elected officials, sometimes not, but people who can make big changes, and we want to pay attention to what they pay attention to, and they pay attention to the news. So that's what brings a public health group like Berkeley Media Studies Group to examine how issues are covered in the news. And what we've learned from that has told us a lot about what the challenges are in talking about health equity and all kinds of issues that would help us change social norms and build social movements. So we want to share that with you. The other thing we do is media advocacy training and strategic consultation for community groups. We do a lot of that through the California Endowment's Health Exchange Academy, and we're happy to tell people more about that if they're interested. And then we also try to think about what journalists do and help them do a better job by suggesting the kinds of questions and stories that they could investigate that would help open up these public health issues a little bit more. So instead of being in this dark room together, I want to invite you into our office here at Berkeley Media Studies Group. This is our lobby, and I want to show you on the wall one of our favorite posters. And I'll tell you why it's one of our favorite posters. It's from Alice in Wonderland, and it's Alice looking up at the Cheshire Cat, and they're having this conversation. And it says, would you tell me, please, which way I ought to go from here, says Alice. And that depends a good deal on where you want to get to, said the cat. Oh, I don't much care where, said Alice. Oh, then it doesn't matter which way you go, said the cat. Oh, so long as I get somewhere, Alice added as an explanation. Oh, you're sure to do that, said the cat, if only you walk long enough. So that's a reminder every time we walk through our front door that we have to have a very specific and strategic idea about where we want to go if we hope to get there. So I'm going to spend the first part of this webinar talking about the strategy behind the communications you would use to foster health equity, and then get in a little deeper to the framing and what that means and how we can use it and how it hinders us sometimes. And then, as I said, Kathy will do an applied example for Alameda County. First, though, we thought maybe it'd be a good idea to say what we mean by health equity.
Right. So as Lori was talking about the Alice in Wonderland quote, with health equity, it's very important to know where we're trying to go, and part of that is having some common definitions and common understanding of what we mean by terms. So a lot of you have probably seen this definition, but we just felt it was important to ground the webinar in it and come back to it because it emphasizes that when we're talking about health inequities, it's not just about the differences in health outcomes. It's about an unjustly and unfairly structured society that creates barriers to health for many people. And within this definition, it's also about power, and we'll be talking a lot about power throughout the webinar.
So the way this translates, this little Alice in Wonderland quote, is into these three ideas. First, that even though we're talking about communications, and this whole webinar series is a lot about communications, and people are sometimes hungry for just the right message. One foundational idea is that message is never first. Before you figure out what you want to say, you have to know, what do you want to change in the world precisely, and how will you change it? What's the mechanism for changing it? And then a third thing we have to also know and be able to say out loud is why. Why do we want it to be changed? That gets to the values that bring us all to this field in the first place, that motivate the work that we do, and that many of us share. But because we're in a room conceptually with others with shared values, sometimes we don't say them out loud. And the problem there is that if we don't articulate them, then other people won't understand the motivation behind what we're doing and be able to connect to that motivation. And I'm going to talk a little bit more specifically about what that means. It turns out to be enormously important if we hope that people will understand the perspective that we're bringing in, especially the policies we think will make a difference. Underlying these ideas are some strategic questions that motivate us and get to the issue that Kathy was talking about, which is power. So the strategic question is, will better community health come about primarily, not exclusively, but primarily, as a result of individuals getting more knowledge about personal health behaviors, or would we see better population health if groups got more power to change social and economic conditions? And I can tell you, I asked this question to a lot of people all over the country, a lot of public health groups, and invariably they all say that we're going to be better off if people get more power to change social and economic conditions. And then I ask them where they spend most of their time working, and they tell me it's the first thing. They work on changing individual behavior and getting knowledge to people. Now that's important. That's really important. It's not really either or here. For example, just one example, obesity prevention. Absolutely, people need to know more information about the choices they're making, what to eat, how often to exercise, but that certainly won't go far enough if groups don't have power to change the conditions. We can't cajole people to eat fruits and vegetables if they have no place to buy them. We can't talk to them about more exercise if the sidewalks aren't adequate for walking to school or if the parks aren't lit at night. So both of these things are important, and because the second one is harder, I'd say even dangerous sometimes because it's challenging the status quo and can be politically dangerous, people tend to revert to the first thing and still feel like they're doing something good, but we feel like they won't be going far enough if we can't do both of these things. And so one of the reasons communications is so important is because it gives us a tool, and a media advocacy tool in particular, to deal with the second question so we don't get stuck only doing the first one. And the reason we have to focus on that second part is because the environment is overwhelming us with the kinds of things that make it harder to be healthy. This is just one example that I know some of you have seen because I know obesity prevention and nutrition is a popular topic right now that people have focused on. And this is an easy way to see how environments can be saturated and overwhelming. And this slide in particular is an illustration of why we can't compete just on the educational front. You can see here we have two billboards. They are both showing African American women. They, on the top is a public health message, kind of a stern-faced woman telling us that we have to take this seriously. And on the bottom we have the McDonald's advertisement, which is joyful, happy, inviting people in. And we simply can't compete with this message. They have a happy message. We have a sad message at a basic level. They have billions of dollars, and that they can be spread widely across lots of groups that are fostering things that are bad for health, from tobacco, alcohol, and food to others. But there's one other thing I want to point out about this. Even besides the fact that the message is hard to compete with, and we can't insert ourselves in the media din because we don't have the resources. Even the California Endowment, in all its generosity, doesn't have enough resources to compete in that way. But there's a third thing that makes it even harder. And I want you to notice that this photograph taken in Oakland, California, has two billboards on the side of what are people's homes. And this is, it looks normal. I mean, we've all seen billboards in situations like this, so it seems just fine. Nobody's protesting the fact that there are families living in those homes that can't escape those particular messages. And the other thing you can't see in this photograph is that there are other parts of Oakland with lots of homes with no billboards plastered on their sides and no billboards in, within eye's view of those homes. We have big differences in the way some populations are living in our cities and towns that make health harder for some and easier for others, not as individuals but across whole populations. And that's why we have to pay attention to how we're talking about this, to the role of health equity and how we can do a better job at it. So what we want to start with is talking about the strategic part of this, and then the framing, and then I say as the example from Alameda County. So here we have a definition of media advocacy. It's the strategic use of mass media to support community organizing to advance a social or public policy initiative. Sorry there, I had to take a sip of water. The strategic use means that sometimes you say no. This isn't about media for media's sake. This is about using the media in a way, in its most powerful form, usually through the news, to influence decision makers. We'll get to that in a second. And it's to support community organizing and public policy. So we don't want the media tail to wag the policy dog. Just like I started with, this isn't a message never comes first. This is about knowing what you want before you go asking for it. So it means that this is about using communications to support the community organizing, to help people raise their voices, and to use it as a pressure tool to change the systems and structures that are keeping people from being healthy. It makes it a little different approach than other kinds of communications, some of which we saw in the first webinar, where the idea was to get individuals more information, to use communications to warn them about a danger or inform them about something they could do for their health so that they would make a personal change. The idea there is to get the right message to the right person in the right way so they do the right thing. And, sometimes that works. Some of us just had to hear once, maybe twice, that if we broke a sweat every day, we'd live a longer, healthier life. And some of us know that knowledge and still don't exercise. So information is necessary but not sufficient for change, especially large-scale change. The assumption underlying that kind of communications is that what's missing is information. If you fill the information gap, then people will do the right thing. And as I said, for some it's true, but it's not true for enough. And some of the research in social marketing and other places has helped people overcome some of those barriers by getting different kinds of messages to different kinds of folks in a way they can accept a little bit better, getting rid of some barriers, and it's useful, but it doesn't go far enough. So if we really want to get to the power structure, we have to think of communications differently. We want to think across issues, not across individuals. We want to think about using communications to pressure decision makers and mobilize the groups that can pressure those decision makers. The object here is policy change, because policy is how we set our rules as a society, and we want to have those rules set in a way that benefits entire population's health. What this means is that we are using communications to raise people's voices as opposed to deliver a message from on high. The assumption is that what's missing is power, and that people need the courage of their convictions, the skills, and the ability to say what's hard to say in different places. Now, it's not just about saying it. It has to be embedded in some kind of strategy. We use the layers of strategy to remind ourselves that we need an overall strategy about what's wrong and how we're going to fix it, and that only then should we pick the media strategy. Once we've got that, we get to the message strategy, which is pretty straightforward. It's simply, what are you going to say, who are you going to say it to, and who's going to say it. So that's the message, the messenger, and the audience. And then the access strategy, by that we mean access to reporters, because reporters have the ability to shine a spotlight on certain issues that will bring it to the attention of reporters. That's a lot of what training is about in media advocacy, but we're not going to spend too much time on the access strategy today. We're going to talk about two things, the overall strategy and the message strategy. The overall strategy, in one word, is that you can't have a media strategy without an overall strategy, and that's what we call the prime directive, and that's just my nod to all you Trekkies out there. Okay, but let's get to the real deal here. Developing strategy, we have a set of questions that we use to guide us. The first is, what's the problem or issue? Now, in public health, we're pretty good about describing this. We have books on it, we have studies, we have reports. All our agencies put out lots of reports. We have a lot to say about the problem. What we're not so good at is saying the problem in one or two sentences. That's because sometimes it feels like a betrayal. Sometimes it feels like if we only talk about a portion of the problem, then we've given up the fact that these are very complicated, complex problems that require lots of different approaches. But in any given situation, even in this webinar, we can't say everything every time. So we have to choose. And we have to choose what piece of the problem we're going to work on and define it well and be able to talk about it succinctly. Otherwise, we're going to give people too much information. They're not going to be able to focus, and a reporter's not going to know what's important about what we're saying. So that requires choices, and it means that we have to have a strategy in place for how we're going to make those choices. A second question is, what's the solution or policy? So if we get done with the first question, then the natural question we'll get from any reporter is going to be, okay, well, whether you convince the reporter or not, because it's not their job to be convinced, they'll say, all right, but what do you want to do about it? And here's where sometimes we fall down on the job. Here's where we say things like, oh, the community really has to come together, or children are our future. That's not what this question is about. Those things might be good, and they might be good to answer, but what we're talking about here is a very specific solution or policy, including who has to do what on Monday, that my friend Chuck McKinney always used to say. So that's the idea of identifying a solution that essentially names names, that says who has responsibility for making that change, which leads us to the third question. Now, the third question isn't answered in some big general way. When I say who has the power to make a change, it might be one person. It might be a school board. It might be a couple of votes on a committee. And so that is very different than how we generally describe a target audience in public health, where in that sense we're talking about the people with the problem. Here we're not talking about the people with the problem. We're talking about the person or two who can fix it. Kathy's coughing because she agrees with me. Then the next question is, who must be mobilized to apply the necessary pressure? That's going to be a small group. That's not the general public necessarily. And the final question is, what do the targets need to hear? And I want you just to look at all these questions together and understand that the primary audience here is a very narrow audience. The secondary audience for who might get our messages is a larger group, but not that big. It's the group that has to mobilize and put pressure on the first one. It's only in a tertiary way would the general public ever be our audience. That's kind of confusing because we want to use mass media to talk to people, and we want to do that through a mechanism that is going to expose the general public. And the general public hearing about these issues through the news can put pressure on our primary target, but really the general public isn't the first audience. So that's all I'm going to say about strategy right now, and that'll come to bear when Kathy talks a little bit about the Alameda County example. What I want to talk about next is framing. And framing is a topic that a lot of people talk about these days. People didn't used to talk about it so much, and they do now. It's an abstract concept. It's about how people take in information, make sense of it against information they already have in their heads, and then act on it, sometimes without even knowing. So it's that's why I'm showing you the foundation of a house. What's underneath the walls is holding it in place even though you don't see it. And in a minute I'm going to ask you to get ready to type on your keyboard in the chat box, because I want you to type in, because I'm going to show you how framing works, and then I'm going to give you this demonstration, and then I'll define it more from the theoretical point of view. But I want everybody to look at it, type in their chat box right now, what are the words they see behind the orange box? Oh, that came out kind of funny, our orange box here, but type in and tell me what you see there. Yes, I'm seeing it one after the other. Keep going, keep typing in there, yeah. Very good. So some people are saying health equity, health equality, it's all coming through. So that's exactly right, you guys. Keep typing. And then what you'll see that's kind of fun here is that, well, that's not what it says at all. Look at that. Isn't that amazing? Okay, let's go back and look at this because it's so much fun. All right, look what you guys did. Oh, Marcel. You guys most of you, except for one or two, oh, I got an LOL, I love that. All right, you guys, sorry, I'm enjoying this too much. Here's the deal, here's what happened. Your little brains filled in the blanks, and you didn't have to say, little brain, tell me what that says. It just did it. It got a small cue, and it saw health equity. It was wrong in this case, but that's what it saw. And that happens not just with words, but with ideas as well. That happens because frames are the mental structures that are already in your brains that help us understand the world. From the time children's brains are forming, the neurons are connecting, and the ideas are joining, and the cognitive linguists who study this think very sort of tangibly and literally about how the brain puts together ideas. I think there's a lot about brain science we don't know, but there's a lot that we do, and people are discovering that metaphors are very crucial to how people understand language, and that all of this happens behind the scenes without you really saying it, without you being cognizant of it. So the other thing to know about this is that this has been happening all your life. So as ideas and things are exposed to you and stimulus come in from the outside world, they get incorporated and measured against what you already know. And this happens, as I said, with ideas as well as just the kinds of words I showed you. And I'm going to, I'd like to skip ahead to this slide over here. I wonder if I can do that, Kathy. Yeah, here I go. So I want to show, the reason I'm showing you this scale right now is because it's an illustration of the fact that the ideas that we get exposed to over and over and over again in our lifetimes, especially if we live in this country, in the United States, reinforce a certain set of ideas that make it harder to understand why a public health approach to community health makes sense. That's because the ideas that we get exposed to over and over again reinforce the idea of personal responsibility. Now, personal responsibility is an important thing and a good thing, and a thing we need more of, especially in high places. But it's not the only value that motivates us. And when it's the value that dominates our public conversation, it makes it harder to see that we also have to bring institutional accountability to bear. And I realize this is a bit abstract. I'm going to show you what it looks like in terms of values, and then I'm going to show you a couple of storylines so you can see how these differing ideas show up. And the reason the scale is out of balance has in part to do with news coverage, because of the studies that have been done for decades now on news coverage that show us that we see far more stories that emphasize people, events, and incidents that reinforce the ideas of personal responsibility than we see stories about people and events and ideas that are embedded in some larger context. It's kind of like the difference between a portrait and a landscape. Most of the stories we tell ourselves about ourselves through the news media and other places are framed very narrowly to focus just on what a person is doing. When people see stories like that and are asked what we should do about a problem, they will answer in ways that tend to blame the victim because they just see the stories of the people. If, however, they see stories that embed a person in some larger landscape and then are asked, what should we do about this problem, then they will answer in ways that include institutions and government as part of the solution to problems, and that in public health is generally what we're seeking. This reflects a kind of a dichotomy of values between market justice, as Dan Beecham called it, and social justice. These value sets operate simultaneously, but we are dominated more by the market justice values that emphasize personal responsibility. economist Jared Bernstein called that idea, you're on your own. It means that you have a duty to your family, to yourself, but beyond that, not much of a duty. And if you have an attitude about government, it's generally that government interferes. That's in contrast to a social justice point of view that holds individuals accountable, but also understands that it's not just personal responsibility, but that there's a shared responsibility. Jared Bernstein called that idea, we're in this together. It means that we have duties not only to ourselves and our families, but also to a collective good. And it means that we understand that government is there also to protect. It's tricky in public health because we can be quite critical of government. It's not doing everything we want in quite the way we want. That's why we need to change policy very often. At the same time, it's how we pool our resources and our infrastructure to make the changes. So it's in the communities that we want to see. So it's a very complicated and complex relationship, again, here that makes it harder to talk about than just saying, oh, government is too big or not doing its job. And so this is a crucial problem for us right now, and especially for health departments. So I'm going to show you two examples, and I'm going to turn this over to Kathy so she can give you the Alameda County example. I want to tell you about the competing storylines that these values underlie. So if we stick with the example of obesity, I'm going to give you an example of violence too, but here's an example of obesity. We have one storyline that essentially you could title, "You are what you eat." And that explains obesity by saying that it comes from poor parenting, that kids have bad habits and are making terrible personal choices, that they have overactive thumbs playing on their video games and underactive legs because they're not out on the playground. And the solution to this problem means we need to exercise, and we need to exercise willpower. And that's one whole storyline that we hear over and over again about obesity and childhood obesity. An alternative storyline is what surrounds us shapes us. This idea is that, sure, parents are responsible for what kids eat, but parents are not responsible for what's on the front of cereal packages or how low those cereal packages are placed in supermarkets. Parents certainly aren't responsible for those billboards that were on the side of the building I showed you earlier. It means that we're going to find health when we have neighborhood connectivity, when there's safety, when transit systems are working, when recreation systems are working, when our parks are well lit, when our sidewalks are repaired. That we have to take into account the fact that there's no time for physical activity in school, and that if we're going to fix this, then it means local, state, federal policies have to be brought to bear. Taxes, advertising, zoning. It's going to be quite a variety, but it means that collectively we're going to have to make choices about these problems. And the thing about these competing stories that makes it complicated is that, of course, both are true. But we have in our rhetoric and in our storytelling, we have more about the first and less about the second. One more example. Here's a competing story about violence, and this is a very interesting distinction I'm going to show you that comes from some very interesting research. So the first story about violence is that violence is a beast. That means it's preying around every corner and lurking in our neighborhoods, and if we want to do something about it, then we have to hunt down and trap that beast and put it away. That's our prison system. And we have to enact harsher laws to make sure that prison system works and catch and jail those criminals. And certainly if people are doing criminal acts, they probably need to be punished. But that's not the only way to think about this story. Another way is to think about violence as a virus. When you do that, then violence is something that is infecting or plaguing our communities. And that means to do something about it, we have to inoculate the community and investigate the root causes for how these things happen. When we do that, we can see that the solutions are to improve education, eradicate poverty. And this is very interesting. What's interesting about this, not just that these two familiar stories show up and that they garner such different responses from people when they're showed this. And what they found in the research is that when they changed just a few words, they had hugely different responses to how people thought about what we should do about the problem. And this is a piece directly from the research. So it says, this was a phrase that they used, and some people got the, got the situation in their research where they read this paragraph like this. It said, "Crime is a wild beast preying on the city of Addison. The crime rate in the once peaceful city has steadily increased over the past 3 years. In fact, these days it seems that crime is lurking in every neighborhood. In 2004, 46,000 crimes, blah, blah, blah." Then some people got a different paragraph. Their paragraph was, "Crime is a virus infecting the city of Addison. The crime rate in the once peaceful city has steadily increased over the past 3 years. In fact, these days it seems that crime is plaguing every neighborhood. In 2004, 46,000, blah, blah, blah." So what's interesting here is there was just a slight change, but when people got the virus metaphor instead of the beast metaphor, then they saw the need for the kinds of policies that get us to the root causes and health inequities that we know we need to put in place to improve communities' health. It's not like there's magic words here, but the ideas are very powerful. And then when you ask people why did they pick the policies they picked based on what they read, on both sides they always said it was the data. But it wasn't the data because the data was exactly the same. So I want to skip ahead here so we can get to a way to talk about this that's really important that's going to lead right into what Kathy's going to say. One of the things when we do finally get to talk about a message is that it generally has three components: statement of concern, the problem, a values dimension, why does it matter, and the policy objective, what should be done. This should look kind of familiar now because it looks exactly like the developing strategy questions we talked about in the beginning. But I want to present to you one other idea and then have Kathy apply this. The idea comes from George Lakoff, and he's done a lot of work on framing, and some of it's fabulous, and some of it raises interesting questions, and some of it I'm not so sure about at all. But there's one thing that he did I really, really like, and it's been very useful to communities all over California that we've worked with. And this is his conceptual levels, and he cleverly named them Level 1, Level 2, and Level 3. And what's interesting about them is how they differentiate the way we talk about things. So Level 1 for George Lakoff was overarching values, big values: fairness, responsibility, democracy. Some people put health there, some people don't, but those are the big values that motivate you to do what you do. That's the reason Level 1 is important, is because it's at the values level that people connect to ideas. Just like we saw with that violence example, people don't connect on the data. They think that's what they're paying attention to. The data are necessary. We have to use it. We define our strategy based on it. It's really important. But we have to also include values if we expect people to connect to what we're saying. Level 2 are issues like children's health, chronic disease, living wage, whatever it is. That's interesting because that can help us kind of walk through a different door on our own problems. If violence, for example, is a public health issue and not just a criminal justice issue, it means you get to invite different people to the table to consider the solution and different kinds of policies that might address the problem. Level 3 are the specific strategies like removing toys from kids' meals, healthy checkout lanes in supermarkets, nutrition standards for foods marketed to children. Those are just some details around in food land, around those kinds of policies. All kinds of different policies are there. What's problematic is if we spend all our time at Level 3 without making the connection to Level 1. If we do that, we're talking inside baseball, we're talking to ourselves, and we're not allowing the people outside of our realms to understand the magnitude of the problem and how it connects to what they care about too. So I'm going to stop there. I'm going to hand the wand over to Kathy so she can talk about how she's taken some of these things and applied it in her work in Alameda County and tried to apply it specifically to health equity.
Hi, everyone. Thanks again for joining us today. And so I'm currently a DR/PhD student at UC Berkeley, and that's part of the way I've connected with Berkeley Media Studies Group and Lori. And I've also been working at the Alameda County Public Health Department in Oakland. And so my research is really at the intersection of these organizations, so thinking about how we communicate about health equity and thinking about the role of local health departments in achieving health equity. And so while I'm still in the research phase, I worked with Berkeley Media Studies Group to develop a blog post about some of the things that have been clear themes in what we were hearing from advocates out there doing communication work related to health equity, themes from literature and research on the topic, and themes from my own experience working at a local health department on the issue. And so these 7 things advocates should know when communicating about health equity are from the blog, which is on the website. And while there's still a lot of unanswered questions, there's also a lot of resources that we can really start using right now as we're seeking to answer those questions. And so I wanted to go more in depth in each of these areas today, and just again acknowledge that a lot of the examples I'll be sharing really come from the great work of my colleagues at Alameda County Public Health Department in our Place Matters initiative and other initiatives throughout the health department, as well as many of our partners and residents that we work with. Okay. So first, as Lori mentioned, before moving into a media strategy or message strategy, we really have to know what we want to change, and this guides everything else we do related to communication. And in my experience, it can be really tempting to skip over this step or really not spend enough time figuring it out, and so I just want to emphasize that for us it's been extremely important. You know, we might want to focus on the message first or focus on the medium, such as using social media, but without knowing what we want to change or who we want to reach or what we want them to do, we really can't produce strong messages or choose the appropriate medium. And in working on health equity, it can be even more challenging because a lot of our goals are very long-term, like eliminating differences in life expectancies, and that requires multiple strategies. But we can still focus on specific things we want to change and then relate that back to our long-term goal. So, for example, I know in a lot of health departments, people get asked to give presentations generally on health equity, or in your organization, you might be asked to speak generally about your work. So even if the people asking us to speak don't give us much guidance on what the goal is, we can define our own goal and relate it to our long-term work. And really thinking about before the presentation, what do I want to achieve with this presentation? What do I want the audience to do after they walk away? And how does this presentation tie into my long-term work on health equity? And this can really just help us focus what we actually talk about rather than just presenting all of the data we have. Another example of how how this has worked in our Alameda County work is that in our local policy initiative, Place Matters, which focuses on education, economics, criminal justice, housing, land use, and transportation, the national initiative that we're connected to asked us to develop a Facebook page. And so we wanted to be more strategic about what we posted and really tried to guide our social media policy with an internal document that outlined how it fit in with our overall strategy, which helps us guide what we post and also prioritizes how much time we spend on social media. And so what it helped us realize was that while social media can support our efforts, it's actually supplemental to our strategies, and we know that it's still the personal relationships that are really driving a lot of our work. So when we have an event, for example, we ask people where they hear about it, and it's still through our staff or somebody personally emailing them, although Facebook's a great reminder. And so this means that, you know, we really are trying to drive our social media strategy by our overall strategy and not just focusing on social media as an end in itself. Another example from our work is highlighted in an issue brief that's on Berkeley Media Studies Group's website called Struggling to Breathe. It's issue 20. And this focuses on community organizations that came together around pollution near the Port of Oakland. And community groups were really spearheading this work, but they also called on the health department to get involved. And one way that we got involved was that Tony Eiton, who was our health officer and director at the time, co-authored an op-ed that appeared in the Oakland Tribune. And you don't have to try to read this all now. I'm going to point out a few things that based on what Lori discussed. And so before getting to the op-ed, community groups and the health department did a lot of work to develop an overall strategy related to pollution near the port. And this meant really they could get really specific in their message and really answer the 3 questions Lori mentioned. what's wrong or what's the problem, why does it matter, and what's the solution. So here on the next slide, you can see that there's a very clear definition of the problem, but like Lori said, it's very short. It's not the whole op-ed, which can be what we are sort of inclined to do given our public health background. And because the real target of the op-ed was getting the port commissioners to make a specific decision, they already knew a lot about the problem because there had been a lot done to educate them. And so they didn't really need to focus on the problem at this point. On the next slide, we show the solution. And so this is really where a decision maker is named, the decision they need to make to promote health equity is named, and in this instance, there's even the time frame specifically named of when they can do this. And you can also see proportionately there's much more space spent on the solution. And so again, if they hadn't had done the work on the overall strategy, they wouldn't have been able to be this specific and spend this much time on the solution. And then the final part I wanted to highlight was the values, or why does it matter? And this gets to the level 1 values that Lori talked about. And so in the first paragraph, the values of justice and prevention are woven into the problem. In the second paragraph, the value of ingenuity is used. If Los Angeles can do this work, Oakland should be able to do it too. And in the third paragraph, it goes back to injustice as well as the value of leadership. And so this is a really great example of weaving the values throughout, not just mentioning the value once, but really integrating them into the whole op-ed, as well as integrating the values into both the problem and the solution. And then thinking about Lakoff's conceptual level 2, at the issue level, port pollution could be framed as a transportation issue, an economic issue, a jobs issue, or in many other ways, but in this op-ed, it's framed as a health issue. So all the other ways of describing it are true, but because that's already been discussed a lot in the media, it was important to reframe this as a health issue and to make sure the health implications would be taken into consideration by the decision makers. And then finally, thinking about Lakoff's third level on the solution or the policy details, that's described here as was highlighted on the last slide.
And as we're going through, please, you can start writing your questions into the question box in the webinar if you want us to address certain questions in the Q&A later. So here we go.
Okay. So the next theme that came out is really that even while we are developing an overall strategy, and that should drive the work, we can start thinking about communication right from the start. And in my own experience, I feel like this is one of the hardest areas because we have so much to do. And really communication can fall to the bottom of the to-do list, especially when we're just working really hard to get a report together or to work on the other aspects of our job. But doing this will help us be much more effective. So for example, if we receive funding to do a health impact assessment, by thinking about our overall strategy and communication from the beginning, we'll be more clear who the audience is going to be for that, what we want them to do, what data and research we want to prioritize to get them to do that, what materials we might need to be developing. It might not be that the whole report is what drives the work. It might be more of a one-pager or a PowerPoint or other materials that advocates can use to testify at council meetings. And it'll also help us think who the best messenger is and help us plan these things ahead rather than last minute. It can also help us prioritize the work because we do have many competing demands, so thinking about what we need to communicate could help us make decisions. And Lori's already given us some questions and tools to think about in this area, and I don't, in my experience, think there are any magic answers in this area. It's just about continually building our capacity and learning from each experience, which means building in time to reflect. So after a report release or campaign, thinking about what went well and thinking about what we could do better, developing simple tools like timelines for planning, keeping communication as a recurring item on our agenda, having a point person or sub-team. All of these are things probably you all know, but it's just reminding ourselves that they're really essential and keeping focused on it. So the next area is really thinking about communication as collaborative and how it can flip the script on power, which goes back to how we talked about health equity and health inequities as being really related to power. And so even if you do have a point person or sub-team focusing on communication, it's important to remember that this is really one area where we have much better strategies and messages when we involve more people, and that all of our coalition members or our team members are communicating about this work every day. So supporting them to be effective communicators is essential. In the blog on the Berkeley Media Studies webpage that this comes from, I just also want to mention I reference a great blog post from Makani Timba of the Praxis Project, and that would be a great short resource to start a conversation in your team or in your coalition with. And she really talks about the connection between community organizing, communication, and power, and makes a critical point that communication strategy and organizing strategy can't be separated. And so really when we think about how we're building the infrastructure to do this work, anyone who's interested in communication also really needs to be working hand in hand with the people who are really working on the organizing and the policy change as well. And so thinking about what that looks like in our meetings and making sure that we build in time for everyone to talk together. It also means thinking about how we are working with those most affected by health inequities, and that they are able to lead the efforts to eliminate them. Otherwise, in our own work on communication, we risk reinforcing the very power relations that we're working to dismantle. So at Alameda County, not all of our policy work includes media, but it does include a focus on supporting community efforts to advance social or public policies that will lead to better health outcomes and decrease health inequities. And the collaborative part has been key for both good communication and for addressing those power dynamics internally. So one example of this is in some recent work that staff at the Alameda County Public Health Department and a lot of our great partners have done around displacement and gentrification as public health issues. And so in this work, we've partnered a lot with a Causa Justa Just Cause, which is a multiracial grassroots organization working to achieve justice for low-income San Francisco and Oakland residents. And in the two articles listed on the bottom, it goes more into detail on this. There's one on Causa Justa's page and one, a journal article describing how we've gone about some of our partnerships. But for our communication, it's been really essential to work with base-building organizations that bring the people power, the campaign knowledge, and a deep understanding of the issues to our work, whether it's housing or transportation or land use. And we've also found by partnering with base-building groups, they're freer of some of the government restrictions and are really able to engage residents in a way that we are not able to do. And so this picture on the top left is Don Phillips from Causa Justa talking to a city council member, and this is a report release for the report on displacement. So, and in this collaboration, Alameda County staff have had a lot of the data and policy analysis skills, and the health lens also brings a sense of objectivity, credibility, and urgency to the issues as we're talking about displacement and gentrification and housing and foreclosure. So this picture on the top right is from the same article in the Chronicle, and that's our health officer and director, Dr. Mansu Davis, who also spoke at the same event. And so I wanted to put this in there because thinking about what does it look like to collaborate and what does it look like to really address power, I think this is a really great example of how a collaboration has been much more effective than if the health department tried to go it alone, and that each organization brought a lot of strengths to it that ended up, as you can see, being highlighted in, it was a front page story in the Chronicle, and really brought out the themes that we thought were most important, that displacement is not inevitable and that local government has a role in ensuring that development occurs without displacing folks. There's a lot more we could talk about that, but to move on, again, this idea that by collaborating, we're also able to go beyond logic because we know that logic alone won't win the day. I think there's a tendency in public health that we think by connecting the dots among social injustices, negative health outcomes, and policy solutions, that's enough to sway decisions. And while this is an important part of our work, what we've seen in communication research and practice is that that's not enough. And so a lot of the tips that Berkeley Media Studies gives for media advocacy are just as important, if not more, when talking about health equity. So this really includes the things like using plain language, avoiding jargon, and using values, and also providing a vision of where we're going. We can spend a lot of time talking about what health inequities look like, but we also need to provide that vision of what health equity looks like. And in Alameda County, we've tried to really incorporate that vision into our materials, our presentations, and our website to talk more and more about not just what we want to fix, but where we want to go. So I wanted to highlight two examples of how we've been able to do this in some of our work. And the first one is from our report on male health status from Alameda County. As Lori talked about, data can be overwhelming. Giving people a lot of information can be overwhelming, and it can only take us part of the way. And so while data has been essential in driving a lot of our work at the county, it helps us maintain our reputation for being credible and science-driven, we've been trying to add other communication techniques to the way we talk about our data. So in 2010, the county released this report on male health, and it included data and policy recommendations, but the staff also interviewed men in Alameda County and connected that data to stories of real people. So this example on the right appeared in the report, and then there's those throughout the report, and the stories of men talking about their health issues and how they relate to the systems that we're trying to change, which provided a much stronger report at the end of the day. The next example ties back to a lot of the work that I just mentioned on displacement, gentrification, and tenants' rights. So earlier this year, Causa Justa, the group I mentioned earlier, led a campaign around tenants' rights in Oakland. And so this is part of the campaign. And so in addition to invoking some of the level 1 values, such as fairness and justice through these pictures, it also reframed gentrification and tenants' rights as health issues at the level 2 level. And so what this picture is our housing work group coordinator worked really closely with Causa Justa to develop a story bank where it included stories from each person as well as pictures. And what was really helpful is our housing work group coordinator actually has a background in journalism and public policy. So having staff with diverse experience has really helped us progress a lot of our work around communication. We use these photos in social media leading up to a city council vote, and a lot of the same people in the pictures were speaking in front of City Hall and testified that night. And we also had staff from our trust clinic, which serves homeless clients, and speak, and they used a lot of the data, but also talked about why it matters and why tenants' rights were really connected to homelessness, and that we needed to address what happened upstream in order to make sure we didn't that we were solving the problem of homelessness. So the city council members voted unanimously to pass rent ordinance reforms in 2014, which was the first rental protections passed in Oakland in the last 10 years. And so this really goes back to the last point and this point, that collaboration was really essential in this, and that as we connect our work to stories, to values, that we have a much stronger chance of swaying the decision makers and winning the battles that we want to win. Okay, and for the next theme that came out is one that we're really looking forward to the next webinar, where John Powell will be discussing structural racism, and as he calls it, structural racialization. What we found is that understanding, addressing, and communicating about racism and white privilege as being at the root of health inequities is one of the biggest challenges in our work. It's very complex, and it intersects with a lot of other forms of systemic oppression, and many people are unsure how to talk about it. But if we want to improve health for everyone in the U.S., we have to be able to discuss these concepts and why they matter. And we have to be able to talk about them as systemic. We know that when people think of racism, they often think of individual acts of discrimination, but we know that reducing inequities requires dismantling entire systems of power and privilege. And so our communication strategy needs to be there. So on the next slide, we describe this more in the public health reports article I mentioned, but what this has meant for us in our day-to-day work is that we've invested the time and resources in creating space to talk about this. And this might be in the form of monthly discussions where we look at different resources, watch different films, have different guest speakers come and talk about these issues. In our Place Matters work, we started our orientation of the work groups with a video of Dr. Kamara Jones from the Centers for Disease Control and Prevention telling her gardener's tale, which is about racism. Really trying to find different ways to create the space for this discussion, because while the context may change depending on what jurisdiction we live in and what policy we're working on, if we don't create the spaces in our organizations to at least start having these conversations, there's no way we'll be able to include it in our external communication around policy. And so we're definitely excited to hear more about what John Powell says, and these resources here are great ways to get started on having that conversation. And that leads into the next point about there are low-cost ways to integrate this into our work. We do want to look for long-term ways to invest in building our communication capacity across the field of public health, especially as related to health equity. But we can also start making inroads now with the resources that are out there. So on the next slide, these are just some of the resources we've been able to use. At Alameda County, we started a monthly group for anyone who is interested in communicating about health equity. That went on for a little while, and we discussed resources like the ones here. We wrote letters to the editor, we practiced interviewing each other, and once we went over some of the basic things like Lori discussed, like the 3 questions of what's the problem, why does it matter, and what's the solution, everyone became really adept at hearing that in other people's interview or letters to the editor and could help each other out with improving it, and didn't need to have a lot of background and expertise, because once you become attuned to these things, you can start hearing, you know, that a letter to the editor missed mentioning a solution, and it becomes easy to help each other out. And another part of this was that the leadership was supportive. Some of the leadership team members attended. They allowed us to write supporting this group into our job descriptions. And so that signaled to staff that communication was a priority. So I think that's another way to emphasize this work, is having leadership on board. And then finally, just reiterating that communication is something we all do, no matter what our specific role is. And we may be talking to a city council member or a reporter, or we may be talking to a neighbor. But because we all are communicating every single day, and often communicating about health equity, we do have many opportunities to help each other. And so I think this webinar is a great step, and we can continue to build ways to help each other out in this area. And I just wanted to open it up on the next slide in the chat room. As you know, you're starting to think about questions you want to ask us, is to also think about what's one step you can take today to improve how you or your organization communicates about health equity. And I would be personally interested. I'm sure there's a lot of great ideas out there, and what people think they might do to start incorporating, or if you've already done work to incorporate this into your organization. It'd be great to hear some of your ideas.
Well, look for those as you type them in, and just wrap up by saying that there's 2 parts to this communications approach. One is that you have to develop strategy. Message isn't first or foremost. You have to know what you want to say, how you're going to get it, who's responsible for making that change, who can put pressure on those people. It's not about news for news' sake. It's not about the general public, even though they're going to get exposed to the idea. It's really about being focused and letting that focus drive what your communications are. And then across all the different kinds of policies that you might be enacting to try to bring health equity into our society, there's going to be 2 consistent problems with framing that you have to pay attention to. One is that in our society we focus on individuals, rugged individualism. That's what people call the default frame, because unless we introduce some other idea, that's where people are going to go. So we have to cue up the landscape. Just like we cued those ideas with that orange box, you have to cue the landscape first in your communications. Order matters here, actually. You want to be able to bring that picture to mind so that when you suggest your solution, they make sense. So that's what we mean about illustrate the landscape. Make it visible. Make the changes that you want to see clear and possible in people's minds so they can be possible in the real world, then as you talk about it, say why it matters to you. Some people are going to want to have public opinion research to investigate the values that their decision makers care about. That's okay. Sometimes we can do that. Sometimes we don't have the resources to do that. At minimum, know why it matters to you, because then you can say that. You can say that out loud. And we know from communications research that people will be reluctant to voice an opinion if they think they're the only ones who have it. And we know that there are lots of shared values here, so we have to be the ones that say them out loud, connect them to our solutions, and make that landscape visible for people so they can see why the policies will make a difference. So we will stop there and turn it back over to Jennifer for the Q&A.
Thank you so much, Lori and Katherine, for your presentation today. And I also wanted to thank all the attendees for their willingness to take time out of their day and come and listen to this. You've given us a lot to think about. And I'm going to go to some of the questions that people have been typing in. I think there's a set of questions that were meant to be directed more towards Katherine in her discussions around the report that she did in Alameda County. Some of the questions are a little more technical, but they are, people are wondering how you measured the efficacy of these reports. And then also, did you get a lot of media hits or media picking up the reports? And were there any NGOs that you know of that were using the reports?
Thank you. That's a great question. I think an important part of it is thinking about how we define efficacy, and that goes back to the overall strategy, knowing what we want to change. And so we're still in the midst of a lot of the work, and not just the health department, but partners as well. And so there's policy recommendations in there. The city council vote was a big win. There will be other policy work coming up. And so one of the ways we're looking at efficacy is, are we moving the needle on those policy issues, and whether it's an out and out win, or whether we're moving some people to vote different ways, building partnerships, building a larger base of people concerned about the issue. So one way to define efficacy would just be the policy wins. Another way would be that by defining it as a health issue, it's created a much broader base of people talking about this, both in the media and with our partners. And so really we've seen a lot more public health folks starting to talk about displacement. Another way of looking at efficacy, we did track media hits. We've definitely had over 30, I think maybe over 35. This included television, radio, newspaper, and also different blogs and different people, different other organizations highlighting it. And so one way of thinking about efficacy, that we wanted to just get this idea in the debate, that displacement is not inevitable, that local government has a role in changing it, and that there's a value in not displacing people. And so we've seen that a lot in the media through the work and through the stories that were covered. And we could do, a next step would be doing more analysis of what those stories covered and looking at the framing. We haven't been able to get to that part yet, but that would be a great next step. So we'll continue to monitor and track that. We know that a lot of people have requested it. We've have either downloaded the report or ordered it, so we're tracking who's using it. And again, just through our relationships, talking to a lot of people who have requested presentations, who have asked us about the report, and have asked partners about the report. So we do know that there's a lot of movement around it.
Great. Thank you for that. In looking at some of the questions that are coming up, I might synthesize some of them because they seem to relate to issues of power, which you raised earlier on in the presentation. So, for example, how do you balance the need for effective strategies and engaging in genuine empowerment of all residents, but not replicate the same power dynamics that I think people are trying to overturn? And then also, I think on a related note, how can we initiate dialogue without leading the core message and being able to incorporate more people's voices into the process?
Those are really good questions, Jennifer. We certainly don't want to replicate the problems in the systems that we're trying to change. And I think Alameda County is a great example of this. No one's perfect, no agency is perfect, but with a very conscious intent. We saw the county find mechanisms for being the ones not to lead the conversation, but to engage in the conversation, and I think that begins with listening. You can make listening a structural part of what you do internally in an organization and as a public agency. And I think the work that Alameda County did with Casa Justa and on the port is an example of that.
And this is Kathy. I would add, again, I know I keep saying this, but it's really important, going back to the overall strategy. And for us, our strategy has been to focus on community-driven policy change, and so we're really clear about community being a value to us. And so when we make decisions, sometimes our work may take a little bit longer because we do place those relationships as a priority. And so if we were moving alone, maybe we could move faster, but we really do emphasize partnerships. So one way this looked is we were able to have some funding to have Berkeley Media Studies do training for our Place Matters team. And instead of just opening up to the people who were doing this work, most of their 40 or 50 hours a week, we opened it up to a lot of other initiatives within the health department and a lot of other residents. And so what that meant is that maybe people didn't have all of the background on Place Matters, so we had to spend more time in the training talking about some of the things we were working on. But I was sitting at a table with a lot of different residents, and they were coming up with the best media bites and the best messages. All of the public health folks were coming up with the sort of boring ones. And so it was really clear how much more effective we were together. And so I think just being really intentional about building that infrastructure. We've been able to take some of the tools Berkeley Media Studies have developed and come up with some activities. Right now, we're working on healthy development guidelines that we hope the city planners will use to guide development. And we're using some of the techniques around what's the problem, why does it matter, what's the solution, to develop activities that will help residents when they're at a policy forum, and they'll be talking to mayoral candidates. And so they're going to use their own words to talk about why city planning matters to their lives, but they'll get some information on crafting that strong message since each of them only has 3 minutes to talk. And so really it's just taking the tools and providing it to the people who are most affected, and just building the infrastructure to work so that there's both the health department leading with its message, but there's also multiple other people who can share their story.
And let me just add one thought to that I think gets to the other part of your question, Jennifer, which is that a message strategy, remember, is the message itself, or what is said, the audience, who it's said to, the target audience, but also the messenger who says it. And so what's inherent in Kathy's description here is that Alameda County has been actively and thoughtfully cultivating a whole set of messengers. And if you do that, you start to expand what the message is itself. So one way to think about it is not just what are the words being said, but who's saying it.
No, it's a good point. Going back to some of the other questions that are popping up, it seems like there are a few that are linking back to the issue of white privilege and race, as you raised up earlier in the presentation. So some of the questions that address this are, for example, how would you suggest that people of color address white privilege in conversations? And another related question is, how do you change a social system but continue with the same system? For example, meaning democracy or the government structure was developed in a way that left people of color out of that conversation or development.
Do you have any easier questions, Jennifer? Okay, here's two thoughts, and then Kathy will chime in her thoughts as well. To the first one, I don't know that it's people of color that need to address white privilege. I think it's white people that need to address white privilege, and that we, and I say we being white, have a responsibility to use the term, bring it up, have illustrations of it, and I don't think it's necessarily easy to do. I think one approach that some people have taken is called cultural humility, which has a whole sort of body of work behind it that people are trying to incorporate into different kinds of organizational practices. So it takes a lot of self-reflection, and one of the things that Kathy talked about in Alameda County's work is the fact that they took what they were doing and did kind of proactive self-reflection. So that's one thing that I think maybe could be very useful, but I certainly don't think it's the responsibility of people of color to talk about that. I think it's the responsibility of white people. And I already forgot what the second question was.
It was around democracy.
Oh, around democracy, yeah. Let me say it again, Kathy. What was the question? Democracy and...
how do you change a social system but continue with the same system?
Right, okay. So here's my one thought about that. Besides, do you have an easier question? And that is that it is enormously difficult and can be terribly disheartening. And sometimes I get really depressed about it and have to think back almost like geologic time. I have to think, okay, I have the vote. There was a time I didn't have the vote. So we can change systems. And we can look at gay marriage right now and what has happened not just in our lifetime but in this recent moment of our lifetime that has quite a long history behind it, but nonetheless has erupted in equity in a time that we can see. And I think pretty soon it won't be long before we just say marriage. We don't say gay marriage. So I take heart in the fact that we have made enormous progress as a society despite the fact we have a long, long way to go. And that, too, I think requires self-reflection. You know, our country put labor laws in place that protected millions and millions of people. We stopped child labor, except, of course, if you were a domestic worker or a farm laborer. So we put laws in place that protected millions and millions of people, yet they were flawed and they need to be fixed and changed as well. So unfortunately, we just can't, say, oh boy, job well done, right? We have a lot of work yet to do, and I toggle between the enormity of it, but also the wonder that we can actually approach the kind of society that we all want to live in.
Great. So my thoughts on that, I can describe a little bit of our Alameda County experience, especially as related to discussions around white privilege. And long, long before I came on staff, there was a lot of work and movement within the health department just around building those areas around discussion. And some of it happened, when there were things like celebrating different cultural heritage. People would bring food. People would focus on the celebration aspect. And then from there, talk about some of the issues that were barriers to those populations being healthy. And then it evolved into being able to talk more explicitly about racism. And then as we talked more explicitly about racism, the realization that white privilege was a central part of the conversation. And so I think that, we've been fortunate, and there's always been a large group of people interested in this topic. If it was an organization where there was a lot of resistance, I think if there are allies who are willing to talk about it, starting out small, doing reading groups, doing cultural celebrations, and then expanding it, I think having that long-term vision of really what it means to connect this work to this overall idea of health equity helps keep moving it forward. But I think all of those discussions have built, and it hasn't felt linear for us, although in hindsight it looks more linear than it is. But we can see that we wouldn't be where we're at today and able to talk about displacement and talk about it as a clearly racialized issue that creates racial health inequities if staff from the health department hadn't been having these discussions for the last 20 years. And so I think just building the capacity and continuing to focus on it. And I'd be really interested in what John Powell has to say at the next webinar. In terms of democracy and sort of changing this incremental change versus upending the system and changing the status quo, I I think this is where it's important. One thing we didn't talk about today is the underlying frameworks we use, which guide our communication. If you have a definition of health equity that doesn't include an analysis of power, I don't think you're going to be able to communicate why we need to shift power. So one is just thinking about those frameworks, and I know with our work with some of our partners in reports that a good chunk of time was just used talking about our frameworks and ideologies, and that really led us to have a more unified language. Although some of the policy change we are doing is still within the system, it's not outside. I would say the partnering with community-based organizations that can take a more radical standpoint and can apply a lot of pressure to the system has been one way we feel that while we're still working in the system, we are pushing for really critical changes that need to happen now, especially around displacement, that if we don't act now, it really is going to have severe, it already is having severe health implications. And so we're working within the system, but a lot of the partners we work with, and some of us on our out-of-work time are also involved in, organizing, going to actions, going to protest, and different things that are also working on changing the status quo.
Thank you. You did cover a lot. The next question I'm going to give you is a little bit more technical. How do you see organizations being able to use social media to elaborate more and make their movement message move forward? What techniques do you see there being for people to help or organizations to help them build their base?
That's a good question, Jennifer. It's something we've been thinking about a lot. And social media is like the shiny new object in the room. Everybody is attracted to it, and it's almost like we're intoxicated by the potential of the reach that it has. We see, Twitter followers, people tweeting and having thousands of followers and things like that. And it's kind of the same as people looking kind of longingly at advertising and marketing and being jealous of the kind of reach that marketers have there. So I think the first thing is just a caution to not be distracted by the potential and to remember that you have to have a strategy behind your social media work, just as with all the media work that you're doing. Otherwise, it can start to take over time without much return. So you can still be strategic about it. So there's a couple things that you can do in a straight-ahead media advocacy sense. One of the things we want to do is build relationships with reporters. Well, these days, Twitter is a great way to do that. If you follow a reporter and start paying attention to a particular reporter because they are reporting on the issues that you care about or your community, that's a good way to establish a relationship, which you can do online, offline, in the traditional way you would, but by starting it with that social media connection, that sometimes greases the wheels a little bit, makes it a little bit easier, and they get interested in who you are in your organization as well. That is important because, of course, then you're leveraging the kind of followers that the news media get and blogs and other places for the issue that you're working on. There's a lot that's been written up about how to develop followers and that sort of thing, and the kind of listening that you have to do in certain online communities before you kind of expect them to pay attention to the issues that you have. And that may or may not pay off. It depends on what your strategy is. As Kathy said, in Alameda County, they do have a social media presence, but they found when they examined it that most of the people who were engaging with them in that deep way didn't come just through a social media connection. People were invited through personal connections that they had. So it can be useful, but it can also be a bit of a distraction.
Yeah, and I would just add, so our work is focused on local policy, which is very specific groups, that we're city councils, school boards, groups that we're trying to reach. And our social media is always supplemental. It's never the main strategy, and it's not necessarily the way we build our base or build our partnerships and relationships. But what we will do is if we're working closely with a partner and we know that there's an issue they're trying to move, we'll just retweet or repost their social media. It's just one way of sort of continuing to build that relationship, but the face-to-face is essential. The being there at the night meetings is essential. You can't replace that with social media. And so it's always supplemental. With the, a lot of organizing went from community partners for the city council meeting around the rent control. And again, that was the face-to-face, the planning, the in-person meetings. But what we did do that night is we live tweeted, and that the tweets were picked up and retweeted by different reporters of small newspapers, small online newspapers, and then those same reporters did stories on the issues and really highlighted some of the health information. And so being there live tweeting was helpful, but again, it's not the main thing. And what was really there was that Kazahusta about the people power. Over 80 people testified, and that was essential. Social media was supplemental.
Keep in mind, too, that social media is different than digital strategy. And digital strategies really are about collecting names, usually for two purposes, to donate money or to take an action. And there are lots of best practices around, and they're not too hard to find on how to do that kind of a digital strategy. But once again, the first question you'll get is why? Why do you want those names? What for? And having that overall strategy really clearly thought out will help you know, one, whether social media and a digital strategy is a good mechanism for getting what you need to happen, and two, if so, where you need to focus.
Well, thank you. You ended that right at 2:30. So I just want to say thank you again to Lori Dorfman and Katherine Schaff for their willingness to attend on our webinar today, and everyone else for listening in. I do want to take a moment to plug our third webinar, which is going to be titled Social Norms and Change, which I believe Katherine mentioned a couple times. It's going to include or be run by Professor John Powell, who is a professor of law at Berkeley Law, and he's also a professor of African American Studies and Ethnic Studies, and the director of the Haas Institute for a Fair and Inclusive Society. He is going to share his research with us on structural racism and how advocates can help contribute to norms change in support of racial equity. So you will likely be getting more alerts about this, and you can register for that webinar when it's coming up on October 14th at 1 p.m. So thank you again to everyone, and I won't keep you any further. We will also be sending out links for the audio version of this. Embedded in that will be the PowerPoint. If people need it separately as a PDF, we can also provide that at a later date. And I believe that Berkeley Media Studies Group will also have it posted on